Good afternoon, ladies and gentlemen. It's a pleasure for me to talk to this very distinguished audience about this, I think, really interesting topic. I mean, we are dealing quite often with some kind of polyps, and what we are really interested these are the neoplastic lesions, the adenomas, and you know it depends how you look at it, in which way, in which country, then basically it's something which we see quite often. A malignant polyp is then if this adenoma, if it changes, if we see some invasion. And then we call it a malignant adenoma, and we know that, for example, this is dependent on the size, how big is this polyp, on the degree of dysplasia, degree of velocity, and where it is basically located. And if you look at one of these studies, this is an old one, but basically you always see the same, that very small lesions, meaning half a centimeter or so, basically are never malignant. But big lesions like 4 centimeters in diameter, so in approximately 80% or so, will be a malignant change. And you also see much more often a malignant change of villous adenomas than of tubular adenomas. And for us, the clinical question is always, I mean, we don't know this in advance. You do a polypectomy usually, and then we ask ourselves, is this enough what we did, or do we have to do something else? So if is polypectomy enough? And I would like to share with you a few things which are well known, but which might help us in our decision making. So the definition for a high-risk malignant polyp, that's what we are looking for, is that if you're not doing anything, there is a good chance that it progresses like cancer, so with a recurrence in the follow-up. And what we can look at is, for example, we can look at the level of the invasion, and we know very well with this old Haggett classification that sessile polyps or polyps, pedunculated polyps with level 4, they are classified as high-risk polyps. We have this excellent Japanese CUDA classification where we know this SM1, 2, and 3. And even if you see, like in this study, that the average would be like 30% of lymph node positive, it makes a difference if it's an SM1 with just 2% or SM3 with like 35%. And this is true to the fact that from the pathological or from the anatomical side, that if we come deeper, we are just closer to the vessels, to the lymphatics, and so the chance of a spread is just bigger there. Degree of differentiation, I mean, high risk, bad prognosis, I think it's obvious. Lymphovascular invasion, we know this is just seen in patients who are never seen in low-risk patients. And the completeness of margin, and it is basically agreed that the resection margin of 1 millimeter is high risk. So we should have at least a little bit more. And the other fact is that, and this is always a little bit controversial with the gastroenterologists, we don't like this piecemeal resection so much, especially if it's unfavorable histology. This is also called high risk. Other risk factors, maybe the pathologist can tell us if, for example, the whole head of the polyp is full of cancer, then it's also a high risk, or if the other adenomas closed by. So, being honest, usually we have to judge, is it enough that we just did polypectomy, or should we do a colectomy? And basically, this is according to the patient and according to the facts what we have. And here, for example, with our judgment of high risk, in at least 27%, like in this German study, for example, so more than a quarter, the residual tumor was seen. Another very good study, I guess, pooled data analysis, more than 1,900 malignant polyps, basically showing the same, that you have to have clear resection margins, that a poor differentiation is bad, and if you have vascular invasion, it's also very bad. Najib Haboubi, the pathologist, once I heard him several times, but once in Florida, I remember a couple of years ago, he gave an excellent talk, and he was telling us, listen, if you have 100 patients, in 50 patients you expect an unfavorable histology. And 10% of this, or 5% of all, will have an adverse cancer outcome if you just do a polypectomy. But you know, basically, you might salvage a few, but in reality, that's very low number when we do a big surgery. And he says that the summary was basically like this, that high-risk polyp resection might be unnecessary in most of the patients, actually, or you have to do 10 patients that they really save one patient's life. So in principle, we know that malignant polyps with an unfavorable histology, they carry this cancer-specific risk, and then we have to basically tailor our approach to the patient. And I think it's not just because we like to do laparoscopy, because it's so funny and it's wonderful, and polyp is the best indication you can have. We just do it, you know, and we just spoke, so maybe this is not right. Just a few words before more important persons like me are talking about this subject of early rectal cancer, but to my understanding, the biggest problems at the moment we have is that we cannot really good diagnose early rectal cancer. And we have various things, and you know, we have MRIs, ultrasound, clinically, whatever we are doing. In principle, the most important things is it's a T1 or is it a T2. We cannot judge perfectly. So this is the weak point at the moment. And we know that in principle that it's not that common, T1 lesions. We know, for example, that anterior we will have, we are more prone to make a perforation or something like this. We know that it's a must that we have to resect the whole specimen if we do something, and incomplete resection, if it's bigger than 3 centimeters, might be a problem. And we know that major surgery, this very distant, usually ends up with some kind of stoma, temporary stoma, with a high morbidity, basically, to say, with a high morbidity. And we have this transanal, and we have this TEM, and there are some studies basically saying that you're more prone to have a good specimen with TEM, although in principle, if you know very well transanal resection, it's also good, something like this. And there are new things coming up, like the SILS port, and we'll see what's coming out. So, I mean, early rectal cancer, I think we can agree what are low risk early rectal cancer. That means small tumors, high or good differentiated, intermediate differentiation, SM1, maybe SM2, and no lymphovascular invasion. And then if you come to the other thing, to the malignant, the high risk, and nowadays I think it's not fair if we just discuss surgery. I mean, there are many other options, endoscopic options, and this is basically often done also by gastroenterologists. But I would just add or just mention a few things. Studies, I think they are somewhat important and maybe in our decision making. The one is here, 2009, published in the International Journal of Colorectal. What they did, there were 23 lesions in the rectum, and when they found out that it was not a good specimen, they did a resection of this. And you see that out of these 6 patients with residual disease, 2 had an adenocarcinoma, 1 a positive lymph node. But what's interesting, after 5 years, there was no recurrence. They just did a simple resection. The other thing was from Germany. For example, what they did, they had 3 groups. So they judged the patients according low risk patients, or the one that the final pathology was higher than expected. And then they had a group where they said, let's wait till something happens. And what they actually could show, that if you do a so-called real operation after an, let's say, extended biopsy, then you call it maybe extended biopsy, then basically the results are the same. That means you do a transanal resection, you do a local excision, and then you find out that it's higher or it's advanced as you thought, and then you do immediately the operation, then it's basically not much difference. But if you wait till you have diffuse lymph nodes, till you have a recurrence, then the outcome will be bad. And I think this is also something we have to consider. And then there's this whole story of neoadjuvant and adjuvant radio chemotherapy, and basically up to now, I mean, I would say nothing of this is really proven yet. But I know that many people are doing many different things nowadays and try the various things what they could do. When you see this transalien endoscopic microsurgery for rectal cancer, when you look at the long-term results, and you see here again that TM might be adequate for low risk, but for higher risk, we don't know exactly. But what's interesting in this study, for example, that there were similar survival rates for T2, although there were higher local recurrence if there were T2 lesions. And the non-surgical treatment forms we have nowadays, I mean, basically we come back to the old Papillon scheme somehow, where the problem is just we don't know how much advanced this is. We don't have a specimen, you know. Some say let's just do radiotherapy or radiochemotherapy, even more problematic somehow. The problem is, even if we do something like this, what's then? Do we have a response, partial response, total response? How we judge this? Do we then go ahead and do a local excision? All these things at the moment are not clear. So in conclusion, I would like to say that malignant polyps, I mean, we have some features which are important and which are called high risk. For example, Willis or Haggett 4 or something like this. For rectal cancer treatment, for high-risk rectal cancer treatment, we still don't know exactly what to do, but we know for low-risk, probably local excision is enough. Thank you very much for your attention.
The discussion is open on this paper.
Yes.
Please.
It's Nicola from Parma. Congratulations for your presentation. I would like to know if you think that the size may be or not a factor for risk of lymph node involvement. What do you think about this? The size of the cancer.
That the size is a risk for lymph node. The size of the polyp, you mean?
Yeah, I mean, straight away. Are you happy to perform just a local excision for SM1 big?
Yeah.
Or SM2 small?
Yes. I don't think, I mean, I cannot prove it, and I'm not aware of any literature. I can't prove it, but to my understanding, if you say that from the anatomy, the lymphatic vessels and the vascular supply is more crowded in the lower level, in the SM3 level, basically, so there's a higher chance of having lymph node metastasis, and just under the basal membrane, there's not much there at the moment. So I do believe that the size of the polyp itself is not important, but the depth is more important. I personally, but I don't know. Maybe others can.
Short reply. Very short.
I don't want to stress about this. I have no experience. I am just collecting some cases, some idea, something like that. I read some paper that, to be honest, in the SM1, this is the superficial one, is the site where is the biggest lymphatic vessel. This SM3 is the lymphatic vessels are quite thin. What we can think that usually SM3 maybe has higher risk of lymph node because it doesn't come SM3 this, but coming this way. So there is big invasion of SM1 submucosa. Maybe if you have experience in this way, there is some suggestion in literature, I don't know.
You have all experts here in the room. I mean, all the experts made, I mean, maybe you ask them, they can answer this.
I think they
Okay. So
I think it's
Okay.
next, after the next, okay.
Mr. Salgado.
Because, no, sorry, but we are on the list.
no, that doesn't matter. But I mean,
So I
the
think
biggest experts
we
are
are-
here. So.